Hi, I'm Mike Dilk and you're listening to the Relax Back UK show, the show that explores all kinds of health topics relevant to you, your family and your friends. Each week I talk to expert guests from a range of backgrounds to inform and entertain you. So please do join the Relax Back UK family and stay tuned.
Hi, and thank you for joining me on the Relax Back UK show. The first topic today is our bad habits and not doing tasks and chores. We might find them boring, but many are ultimately good for us.
So if we think of it from a rational point of view, you would think that we want to do things that benefit us, and yet we don't. And to me, that as a psychologist, that's interesting. That's a little bit puzzling.
My guests are Dr. Venetia Leondaki. She's a consultant clinical psychologist and fully trained psychotherapist, and also Miranda Pastucci, a dental therapist. Then, this is very scary and alarming.
55,000 men are diagnosed in England every year. 12,000 men die in the UK, so that's 1,000 a month. The statistics are awful.
I speak with Tony Collier, a prostate cancer patient, about prostate cancer, getting tested, screening programs, all kinds of stuff. So please do stay tuned for a great show. Thank you. My first guests are Dr. Venetia Leondaki, consultant clinical psychologist and a psychotherapist, and Miranda Pastucci, a dental therapist. So my first question was kind of a simple one, slightly off topic, but it was, what is the difference between a clinical psychologist and a psychotherapist?
Well, clinical psychologists have completed a doctorate and they have focused on research, and they may be trained in more than one types of psychotherapy, or at least can draw to different types of psychotherapy, while a psychotherapist has focused specifically on therapy, and it may be a particular model that they are trained in. The focus is kind of seeing people in the consulting room and mental health, while with a clinical psychologist, you may have a much broader range of activities that they engage in.
Okay, all right.
But it's very confusing for people. I know the amount of
Yeah. You must get asked that all the time.
Yeah.
So I've got a similar question for you, Miranda.
Yeah.
A dental therapist. I haven't heard of that before.
No, and again, it's a question that I get asked all the time.
I've never done anything novel in my life, so there's no reason why I should start now. So
okay, that's fine. But a dental therapist, the easiest way to explain it when I explain it to my patients is it kind of sits in between what a dental hygienist does and what your dentist does. So we can do everything that a dental hygienist does. So look after your gums and clean and polishes and really intense sort of gum treatments. But then I can also do fillings and checkups. So you can come to see me for your checkup, and if you need a filling and you need x-rays, things like that, I have a scope of practice that sits quite nicely in between what a hygienist and a dentist does. So it's great because, you know, these days we can see patients without referral from a dentist. It used to be that we have to see everything. A dentist would do the checkup and then everything will be referred to us. But these days we can actually see our patients for a checkup, treat them for treatment within our scope of practice. So like I said, a filling, a scale and polish. And they would only then be referred to the dentist when they need complex treatment. So yeah, that's kind of it, like in a nutshell. Still very similar to what a practice nurse does in a GP surgery.
Okay.
Yeah.
All right. No, that describes it perfectly. Thank you. All right. So on to the topic in hand, which is kind of all those funny, well, not so funny tasks, many tasks that we kind of in our lives that we cut corners on, don't do properly. What kind of tasks do we generally cut corners on? What sort of things are we talking about here? Either of you.
Yeah, either of us. Well, we found that the vast majority of people in the UK do cut corners, and that can be, the reasons ranging from that can be lack of time or too tired. Mainly domestic type chores can be the most common activities where people cut those corners. So putting the dishes away, the groceries, personal grooming. I think from some of the research that we've conducted at TP is that 26% haven't actually bothered to finish a TV show or a book because, oh, you know, we'll finish that another day, we'll finish that another day. And it might seem like a time saver, but actually a third of people then have to redo those tasks because they haven't done it properly in the first place.
I mean, so these are all boring tasks. And if the book isn't finished or the TV program isn't finished, it's because it's boring. You know, well, I suppose my question is this really news? You know, we don't like doing some jobs, so we won't do them, or we won't do them properly, or we'll put them off. I don't know if you're old enough to remember Fawlty Towers, one of my favourite shows. All right. Basil Fawlty, who, let's face it, was a rather nasty piece of work, says to his wife one day, "Can't we get you on Mastermind, specialist subject, the bleeding obvious?" I mean, this... We don't like doing boring stuff. Isn't that just the human condition?
Well, when you put it this way, it makes a lot of sense. But some of these boring tasks are so important. So we're talking about cleaning our house, tidying up, and brushing teeth. These are things that will have good that will bring good results for me, that they are beneficial. So if we think of it from a rational point of view, you would think that we want to do things that benefit us, and yet we don't. And to me, that as a psychologist, that's interesting. That's a little bit puzzling, because we want to think of ourselves as rational human beings, that we make good decisions. So when you start thinking about it in this context, then it makes you wonder, but why, how come and we do this? How come and we skip things that are good for us? And we know that they're good for us. Things like dental hygiene, there's so much information out there to say it makes sense to look after your teeth, because if you don't, you will pay the cost later in life.
Yeah. But then other chores, like, washing the car, that is not good for me. I can only think of one time in my life when washing the car has been good for me. That's when my second child was born. My wife said, "There's no way I'm taking the baby home in that car. You better do something about it inside and out." Other than that, there is no point washing a car, is there?
Well, I don't know. When I go to holidays in Greece and my car is full of sand, and I bring all the sand into the house, I do hate this, but I also don't like washing the car, so I completely empathize.
But then all that sand that you're bringing into the house, you then have to clean it up. So if you had a clean car in the first place, you wouldn't need to do more jobs. So yeah, I totally get it. We've all got jobs that I hate loading the dishwasher. It's just one of those things. I just hate doing it. But if I don't, I won't have clean dishes to then eat from. So it's one of those that we don't always think about the long-term effects. And obviously, especially with oral health, we don't think about the long-term effects of skipping that nighttime brushing when we're tired, that in between cleaning. A lot of people miss that out, and it's thinking about those long-term effects and what that can mean later down the line.
Often it comes down to time, doesn't it? Because actually, for some jobs, let's go back to washing the car, it doesn't really matter if I don't wash the car for a week or two. But if I don't fill the dishwasher, things start to get a bit unhygienic, potentially. If I don't brush my teeth, absolutely, things start to get a bit unhygienic. So we're always juggling jobs and time. I would have thought that's really the crux of it, isn't it, Benicia?
Absolutely, Mike. We face countless decisions and competing tasks every day, which is why human beings need to be economical with the resources, how we spend our time, how we spend our energy. So it may look like cutting corners is an adaptive strategy because it allows us to take shortcuts, but it comes with a cost. And the cost, it may be about long-term consequences, or we don't finish something and then we have to go back to it, and then we end up spending more time and energy. And I think we often overestimate the effort needed and underestimate the value, which is why we like cutting corners. I also think we're talking about tasks that you're right, they can be boring. They're mechanical tasks, I will call them. And we are so used to what we call goal-directed behaviors, which are driven by rewards, things that are more exciting. And we seeking them. And mechanical tasks are useful, but they don't give us this kind of buzz. And maybe that's why we think they're not important. And we are in a society that very much reinforces, reward-seeking activities.
Sure. So give us an example of a couple of these tasks that are a bit more reward-giving activities that we're more likely to do rather than loading the dishwasher or cleaning the car, brushing our teeth.
Well, maybe this podcast is such a task for you, because I imagine you do this because you enjoy it, unless you're one of those people who hate their job, but they have to do it. So maybe preparing for a podcast and meeting some kind of deadline is something that you will get rewards from. And even if you don't like your job and you don't find this rewarding, you may be afraid of negative consequences that will come. Like, I don't know, your boss telling you off or not being paid at the end.
Well, I can put you to just mention that the reason I do this, because I enjoy chatting to the people. I actually don't get any money from doing this. So so just to put you guys on a pedestal, the main reason I do this is because actually it's quite good fun chatting to people like you. My wife talks about tasks at work. This might be off topic a little bit. I don't know. You may have come across this. And so she's a scientist, and a lot of the stuff she does is admin around that. And there are so many things in her job that are controlled by apps. So if you can't do this particular thing with the app, you can't move forward on anything. And she comes home and it's like the app or the particular system controlled by a computer that someone has to tick a box controls her whole life. So she can't get a lot of these tasks done because, the computer says no. And this drives her absolutely nuts to distraction. Now, have you come across this kind of issue more in the workplace? I would suggest that it's lots of things you can't totally control, so you can't get them done. So you can do 80% of it, but the final 20%, the sign off or the final bit. So you've got to do things not 100%, otherwise nothing will ever happen.
Not something I have come across, not something that I'm familiar with. But it feels like you almost have to complete something to be given permission for the next stage, the way you describe it.
Pretty much, yeah, this kind of thing.
So, like almost playing a video game. So
yeah, get on to the next level.
Yeah, you're stuck at a certain level and you're just like, oh, I just want to get to the next level, and you just can't. And you have to
elements of that. All right.
That gratification afterwards is like, oh, I've done it, so maybe it's that.
It would have been useful to have a way of bringing this into real life when it comes to mechanical tasks, that we need to make sure we complete something before we, I don't know, move to the next level, get some kind of reward. But unfortunately, there's not. It's something we will have to create for ourselves to have the habits.
So on to the topic that I know you guys want to talk about, and I as far as teeth and finding time to look after your teeth. Now, I have a suspicion that when I go to the dentist or the hygienist and they say, so, Mr. Dilk, have you been flossing for the last X weeks, X months? And when you say yes, well, most of the time, and actually you haven't really, they always know, don't they? We
know, absolutely, we do know. We're like, sure, that's fine.
So how do you try and get people to do this boring task, knowing full well that they haven't done for the last few months, even though they've told you they have? How do you persuade us to actually do these dull things?
Yeah, and I can absolutely sympathise of all the things that we've just talked about, the loading the dishwasher and things. We've all got those jobs that we don't like to do. But it's about educating people and giving them that onus of their own health. So, you might think that brushing alone with your toothbrush is enough, but it actually only cleans 60% of your tooth surface. It's those in-between areas of our teeth that get missed. So there's, up to 40% of your tooth surface that gets missed. And in those areas, plaque, which is bacteria, build up in those in-between areas. And that can lead to further problems down the line. So you get a build-up of that plaque and that bacteria, can lead to gum disease, the first sign of which is your gums start to look a little bit red, a bit puffy, which is how I know that you've not been flossing for a little while. And then it starts to bleed, or you start to notice that you have bad breath or other health problems. You know, severe gum disease is related to other general health. So you're at a higher risk of heart disease, strokes, Alzheimer's. So it's just educating people to try and make them understand, well, actually, this has a long-term benefit just by doing this one little job. This little healthy habit will last you the lifetime. You might not see the results straight away, but in your older years, you will keep your teeth for longer and they will be healthier.
Okay, but I'm definitely going to come back and ask you about the other, you mentioned other health related issues that might stem from that. But before that, what was wrong with the old dental floss? You know, we had a bit of string and you shove that between your teeth and give it a good tug.
Sure.
You get most of the gunk out. That seemed to work quite well, didn't it? We're talking.
Yeah, absolutely. And there's still a place for dental floss in those tight spaces. But as we age, it's a natural process for our gums to recede and those spaces between our teeth get a little bit wider. And naturally, just our anatomy is that we have tighter spaces around the front of our mouth. And as we go further back, those spaces naturally widen. And using floss in those areas doesn't quite cover the same surface area as an interdental brush. So an interdental brush is actually more efficient in cleaning in between those areas. In tight spaces, absolutely, floss is brilliant. Interdental brushes in those other areas.
Okay, so these interdental brushes, do they come in different sizes then?
Absolutely, yeah. So there's a different range. With the TP range, it starts off at pink, and that's super, super small and tiny. Again, if you're not quite at that floss stage, that's the brush that's your introductory brush, and then it goes a whole range of colours, and some of them are quite large, but people do need them, and it just creates that feeling of well-being for patients when they do get into the habit and they're like, oh, things feel so much cleaner, and I'm not conscious of bad breath anymore, and I just generally feel like I'm just looking after myself a little bit better. And yeah, if you want more information on those range of colours and how to use it, it's tpdirect.com. People can look for information there.
So do you put toothpaste on these little brushes before you shove them between your teeth?
You can do. It's up to a person's preference. You can dip them in some mouthwash and then go in between, or you can use them just as a dry brush as you would do with floss. Toothpaste might get a little bit messy, but absolutely, because some people just like that fresh feeling, which is quite nice.
So we're racking up on some time here. So by the time we've done our 30 seconds of quadrant regular toothbrushing, that's 2 minutes.
Perfect.
And then we've done a bit of sluicing. That's going to be another 30 seconds maybe. How long are we going to spend with these interstitial toothbrushes or dental floss?
Well, my recommendation would be to use your interdental brushes before you actually brush, because again, habit formation, we've been talking about that, is I find lots of people will use their toothbrush, everything feels nice and clean and fresh, and like they see that little interdental brush on their sink and just like, oh, I'll leave that for another day. Everything feels clean. I'm tired. I want to get to bed. Use your interdental brush before you brush, because then you're not going to not toothbrush. And up to a minute maximum. We don't need to spend hours and hours sawing away things in between. Just a quick in and out, each individual brush. Then you toothbrush. Ideally, no mouthwash, because we should spit, don't rinse after brushing, just so that you're leaving some of that toothpaste behind with all the great ingredients that toothpaste has. And that's it, job done.
So we're looking at like 3.5 minutes.
3 minutes max.
Which in the scheme of things is not that long, I suppose.
It really isn't. And like I said, do it before you brush, job's done. You can feel great about yourself, brush your teeth and get on with the rest of your day.
All right. I want to pick up on a couple of things that you mentioned. Talking about a link between keeping your teeth clean, oral health, and some other quite serious diseases, heart disease, Alzheimer's. Tell us about that. Is that real? Has this actually been researched?
Absolutely, it's been researched. There's lots of papers. There's lots of research going into this as we speak. It's all to do with the bacteria in our mouth. Yes, we have good and bad bacteria. but some of the really nasty bacteria that comes along with severe gum disease, and I'm talking about gum disease that's been going on for a very, very long time, is actually been linked to certain conditions and high is that risk of, as we've just said, heart disease, stroke, rheumatoid arthritis, an inflammatory condition, Alzheimer's. So yeah, having that awareness that all these healthy habits do actually matter in the long term.
Okay. Are any of those papers, are there links to any of those papers or on your website or anything like that if people are interested in that sort of thing?
TP.com, you'll be able to find some research there, just to look at all that. But even if you go on Alzheimer's, any kind of British Heart Foundation, there's links there as well. So, but TP.com is where you would find research.
Let's pull back again just a little bit on things in general, cutting corners in general, not just teeth. If people want, I don't know, help and advice on how to try and finish off the boring jobs of life, where can they go for some guidance, Venetia?
Well, look, I think a lot of this comes down to repetition. So we're not talking about anything too complicated here. It's just how we can find ways to persevere and engage in these daily habits. And we do this again and again. And there can be simple changes in our environment that can help. So any kind of environmental cues help us with remembering this kind of boring mechanical tasks. So if you're trying to get into the habit of cleaning between your teeth, maybe you want to have some interdental brushes around your bathroom, so you remember to do it. Or it's another way of looking at it is you could set yourself a challenge. So, say, how many days in a row can I do this without failing? And if you're successful, give yourself a reward. Think in advance of what this reward is going to be. Find something that motivates you, and you could aspire for this. And it will not always require so much effort. That's important to remember. So habits can take about 2 months for most people to build them. It can take longer too, but let's say about 2 months. So it may take a lot of effort early on, but then we're talking about rewards that will last for a lifetime. So it is not worth investing a little bit more time in these early days of trying to establish a new habit.
I'm going to ask you a very selfish question. All right.
Go ahead.
I have just acquired an exercise bike, and I'm planning to use this thing.
Yeah.
I've used it a bit. Okay, I'm just at the start of my exercise bike journey. I want to do a program where I'm going to use it like 3 times a week, something like that. So it's not like every day at 6 o'clock in the morning or something like that, or at least not yet. I need to try and get myself into the habit of doing this and wanting to do it. Give me some tips on how to make this happen.
Look, I think planning is important. How you make time during your day, and you're talking about 3 days a week. Is this going to work better for you? Could it be that 10 minutes every day works better to start with? I think experiment with routines that are going to work well for you, and it can feel really hard when you exercise muscles that you haven't used before. So it may be that you want to be gentle to yourself early on. If it feels hard work, have some kind of routine afterwards that will be more soothing or rewarding. And remember, if you carry on doing this, it will eventually, probably something like exercise, it will feel rewarding because it releases endorphins. So exercise, even though it feels really hard to get it going early on, it is a rewarding activity, and it will make you feel good about yourself. And we're not talking only about long-term kind of consequences like preventing Alzheimer's disease. I think you will probably end up feeling better every time you cycle after you have gotten into the habit of doing it, and your muscles are stronger. So, kind of remembering this, it's not always going to be as hard as it is early on, and it's about persevering these early days of trying to establish And
All
you.
right, I'm going to take that all on board. Thank you very much, Venetia. And Miranda, give us the website. You've been talking about looking after our teeth with these TP brushes. Give us the website for that one more time.
TP.com. But if you want to buy our brushes, TP Direct.
Excellent. Both of you, thank you so much for taking the time to have a little chat today. Much
You're
appreciated.
welcome.
It was
Thank
really
you.
nice meeting you.
My next guest to discuss various different aspects of prostate cancer is prostate cancer patient Tony Collier, BEM. And actually, my first question to him was, what does BEM stand for?
It's the British Empire Medal that was awarded to me in the Queen's Honours in 2017 for my services to the community in Cheshire where I live. And it was mainly around my work in my hometown of Altrincham, where I basically helped the town regenerate itself. I was one of a team of people that did it. So the award wasn't really for me. It was a recognition of the work of the team in regenerating the town. So, yeah.
Oh, okay. Well, we'll have to do another show about that because that sounds that sounds fantastic.
Yeah.
The topic of this show is prostate cancer.
Yeah.
So let's start off with some basic sort of statistics. In the UK, do we know how many men are diagnosed with prostate cancer, and also the kind of gruesome statistic of how many men die?
Yeah, well, at the moment, 55,000 men are diagnosed in England every year. 12,000 men die in the UK, so that's 1,000 a month. The statistics are awful. We have some horrendous issues at the moment around access to best treatments, and we've got a situation where men diagnosed with metastatic prostate cancer aren't getting the best standard of care. And particularly for older men, where I think possibly because they're considered to be a little bit frail, maybe, or too old for the most aggressive treatments, are actually receiving substandard care. And it's actually really worrying because it's about 50% of men living with advanced prostate cancer are getting substandard treatment.
We'll come on to that because I want to question you about that because that's very important. But let's just rewind a little bit, and you kind of touched on it a bit in the statistics. Do we have any breakdown at age breakdowns at all?
Yeah, it's more common in the older men. So the most commonly diagnosed age group is 70 to 74. But of course, if you just think of it as being that age group at the greatest risk, you then forget about the people like Sir Chris Hoy, who was diagnosed at 47, and I was diagnosed at 60, and one of our ambassadors for Prostate Cancer UK died at the age of 49, having been diagnosed at 44. So it's not just an old man's disease, but the risk is greater as you get older, and the age range where people are most diagnosed is 70 to 74.
And the fact that it is so common, you've given those statistics, means that there's a lot of men who are household names that have had it and recovered from it. And actually, I did a little bit of Googling before we chatted, and I found that there's a long list of household names.
Yeah.
Stephen Fry, he was up there at top. Nelson Mandela, I heard Stephen Fry had it, but I didn't know Nelson Mandela had. Colin Powell, Robert De Niro. And the other one I came across, you just mentioned, Sir Chris Hoy.
Joe Biden.
Joe Biden. All right.
Yeah.
Okay. So lots of people. In fact, there was an announcement yesterday or the day before that David Cameron. Did you hear that one?
I did indeed. Yeah. And I mean, it's sad for him, but at least he was diagnosed early when his cancer was still curable, and that's one of the most other important messages. That lots of men are not being diagnosed early enough, and I was diagnosed way too late. I know we're going to talk about that, but early diagnosis equals curative treatment, and David Cameron hopefully has been cured.
Well, I mean, let's look at that now. So David Cameron's obviously a big name. Everybody knows him. It doesn't matter whether they like his politics or not. The fact is, people have heard of him and will sort of sit up and think, "Oh goodness, David Cameron had prostate cancer and was successfully treated as well." This stat that came out with the press release, this is the kind of stat that I found most distressing, really. I think 1 in 8 prostate cancer patients are diagnosed with the let's try and say that again.
Metastatic.
Metastatic disease, which means it started to spread.
Yeah.
Which effectively means really it should have been or could have been discovered earlier. And that's the big deal here, I suspect, isn't it, Tony?
Yeah, it is indeed. Those stats, though, actually, it's 12% of men diagnosed with metastatic prostate cancer. But those stats actually hide a multitude of sins, because if you look at the regional variation, in the northwest of England, where I am, it's 17%. In Scotland, it's 35% of men are diagnosed metastatic. In Wales, it's 19%. And in London, it's only 12.5%. So there are clear issues here about things like socioeconomic deprivation, ethnic risk, because black men are at twice the risk of white men.
And is that just a function of the genes, or because they're less likely to get checked out?
Yeah, we think it's genetic and a little bit of them not being very good at going to the doctors like most men, but actually probably a bit worse than most men. But I think, there's a massive ethnic risk and then familial risk. So, once you're in the club, your male heirs, like my son and grandsons, are at 2.5 times greater risk. So we know that we're not getting best access to treatments. We know we're not getting diagnosed early enough. And that's not going to happen until we get a screening program, because we don't screen at the moment.
Right. Well, those variations you mentioned are frankly enormous.
Yeah, I mean, 35% in Scotland is dreadful. It's bad enough having 17% in the northwest, but I think it is clearly linked to things. I mean, Scotland, I think, is a bit unique because it's obviously a big country with a relatively small population and very, very widespread. And I suspect access to care is probably a bit difficult.
Right.
But actually,
just from geography, you mean? You've got to travel a long way to go and see a doctor.
Yeah, if you think, that there are not that many cancer hospitals in Scotland, it's always it's going to be a problem. But, certainly in the northwest at 17%, a lot of that is due to sort of socio-economic deprivation and the ethnic groups. So, Asian men don't generally relate very well with healthcare, and the black community are a bit reticent of coming forward. So, and then of course we have in Greater Manchester, we have some of the highest areas of social deprivation in the UK. So inevitably in those areas, men are not getting diagnosed early because of the stupid system we currently have,
right,
where a man has to ask for a PSA test. They have to make an informed decision about whether they want a test. But that means they've got to know that they need to ask for a test because there's no screening program. Right. So because men don't know they need to ask for a test, they don't ask for the test. And then sometimes when they do ask for the test, the GP says no, which is remarkable.
It sounds like you've got some fairly strong feelings about this. So if you were put in charge of this particular aspect of health, men's health, tomorrow, what's the first thing you'd do?
Well, I think the most important thing is that men need to be diagnosed early when the cancer is curable, because early stage prostate cancer is completely curable, but usually asymptomatic. Late stage cancer like mine is not curable. And, I was given a 2-year prognosis. And, the harsh reality is that if we don't diagnose men early, we're going to end up with more and more men like me, and that number of men being diagnosed too late is going to continue to grow. So the only way we can stop that is with a screening program. I don't think we're going to get a national population-wide screening program. The National Screening Committee will be making a decision on Thursday about that. And I suspect we'll get a sort of limited cohort screening of the men at most risk. That's a step in the right direction. But we definitely need screening to stop this happening, and preferably at an earlier age for those in the risk groups.
Okay, so a couple of questions there. Are there any negatives from the screening? Is the reason it might not be everybody is because actually there are some negatives that need to be taken into account?
Yeah, and if you go back 25 years, men who had a PSA blood test, which is the starting point for the diagnostic process, went straight to transrectal biopsy, which is not very pleasant to start off with, but actually could lead to sepsis and death. And then men with very low risk indolent cancers were being treated radically, having the prostate removed or radiotherapy, which was causing them potential harm. Now, the diagnostic pathway has changed out of all recognition, because we now don't do transrectal biopsies, or we shouldn't do. and we don't do a biopsy before an MRI scan. And more men with low risk cancers are going on to active surveillance. So the balance between benefit and harm has now swung in the favour of benefit away from harm. But I think the bigger issue is probably if we had a national population-wide screening programme. At the moment, it would probably submerge the NHS. It would have to be resourced and funded in the first instance. And
Right.
we actually know that we can actually do screening of the highest risk cohorts for about £25 million because Prostate Cancer Research did a paper about that and assessed what the cost would be and what the resources would be. That's
Right.
0.01% of the NHS budget.
So obviously £25 million is a lot of money, but in the scheme of things, not very much. And I'm sure someone, not just on the back of an envelope, but will have done some work on, well, if we do this screening, catch this early, easier to treat, therefore the saving will be. Have you got information along those sorts of lines?
Yeah, I mean, to be honest, it's exponential. The cost of keeping me alive so far has been about £300,000 over 8.5 years. That's going to get worse as my health deteriorates. The cost will be much greater. So if you multiply that by the number of men who are diagnosed metastatic every year, we're talking a huge amount of cost. And you talked about what we need to be doing to improve things to, for better outcomes. I think the other things that we need to be thinking about are making sure that men, when they are diagnosed with metastatic prostate cancer, are able to speak to their clinicians and make an informed choice based on shared decision making. So the clinician says to the man, these are the options. Because you're 78 and a little bit frail, chemotherapy might not be appropriate for you, but this is. And those conversations aren't happening because we know that 50% of men have been undertreated, and particularly older men. So we need to address that because until we get a screening program, we will still end up with a lot of men being diagnosed with metastatic prostate cancer, not getting the best standard of care. And we've got to do better.
So this is another part of the press release that I found really quite alarming. And it's worth repeating. You just mentioned it. Less than half of men with incurable prostate cancer receive the latest treatment or the best treatment for them.
Yeah.
This is very alarming. And and you mentioned it a bit, but it's worth reiterating. What can we do about that?
Well, I think there's a big education process there. I mean, I spoke at a cancer conference in Berlin a few weeks ago, and the audience was oncologists and oncological nurses, and we gave them a case study to start off with an audience of about 500. And this is a case study, 72-year-old fit man with metastatic prostate cancer. This is his burden of number of tumors and so on. What would you treat him with? And 5% of the audience said we'd treat him with substandard care. That for me is alarming, but at least those people will have heard from the 3 professors of oncology that I was on the stage with that they should be doing more. And it's now considered for metastatic prostate cancer that men should have at least 2 therapies and probably 3. So hormone therapy, which removes testosterone, an androgen receptor pathway inhibitor, which is basically a testosterone blocker. It blocks the testosterone getting to the cancer cells, which stops it from feeding, and chemotherapy. So I'm on 2 of those. I'm on hormone therapy and the androgen receptor pathway inhibitor, but I managed to avoid chemo. Yeah, I was actually fit enough to probably have had chemo because I was only 60 and I was training for an ultramarathon. So I was 10.5 stone dripping wet through and one of the fittest non-professional athletes you'll ever come across.
Mm-hmm.
And so I could have tolerated chemo. As it happened, the 2 treatments that I'm on have been incredibly effective and have
Yeah,
kept
so let's just hear your story. So you were a very fit man,
yeah.
and 60, so
Mm.
not middle aged, but not old really.
No, I mean
I'm very nearly 60, so I'm saying you're not old. You
yeah.
weren't old.
Well, the previous year I'd run an ultramarathon in South Africa called Comrades, and I was going back to do it again. And I developed what I thought was a groin strain in the February before the race in the June. And in the May, I saw a sports injuries doctor. We arranged an MRI scan. He saw the scan and said, ugh. And literally the following day, after a blood test, chest X-ray, and a CT scan, he phoned me up and said, 99% certain it's prostate cancer. And within 10 days of, things like biopsies and bone scans, it was confirmed as metastatic prostate cancer that had spread in every bone in my body from pelvis to skull, virtually had a tumor in it. And they told me I'd probably had it develop in 10 years. Now, I didn't know that I'd had a right to this PSA blood test from the age of 50. And if I'd had that PSA blood test every year from 50 to 60, my cancer would probably have been diagnosed early when it was curable, which is why I'm so passionate about men getting screened, because there is no way of starting the diagnostic process without that blood test. And so the quicker we get a screening program, even if it at the moment starts with that and then goes on to MRI scan, which is now the diagnostic pathway before biopsy, that's a big step in the right direction, and it will prevent more men. But I think at the moment, the best we can probably hope for is highest risk cohort screening, so the men at most risk.
Okay, and that is
So,
men that are 65 to 70-year-old.
No, it's actually, if you're a black man, it's 45. If
Okay.
you're a man with a family history, it's 45. And for all other men, it's age 50. So the risk increases as you get older. So we typically want screening for, we're at the moment, what the big ask at the moment of the National Screening Committee is to screen men with the BRCA gene mutation, men with a family history, and black men from the age of 45. I don't think we're going to get population screening. We've asked for that anyway, but I think the answer for that will be no, because we've got the Transform trial about to start, and the Transform trial is a £42 million screening trial to work out what the best way of screening for prostate cancer is that causes the least harm. And that will give us some preliminary output in 2 to 3 years. So hopefully that will be definitive, and then the trial will carry on into a much bigger group of men.
Okay, but in the meantime, if you don't fall in one of these groups and you are at all worried,
so if you do get symptoms,
what should we do?
Yeah, if you do get symptoms, typically it will be sort of pee orientated, getting up a lot during the night or not being able to pee, or if you pee in blood, then that's a problem. But typically those are the things that.
Tell me about peeing a lot, because look, I'm nearly 60.
Yeah.
Most nights I need to get up to pee. Now, generally once. I'm not getting up to pee 3 or 5 times a night unless I've been on the beer. But that's that's also not good for you. But that's not really what we're talking about.
No, I think if you're getting up to pee 3 or 4 times a night, then that's an issue. It's not necessarily prostate cancer, incidentally. Pee orientated symptoms are also symptomatic of things like an enlarged prostate or prostatitis. So it can be just because
prostatitis.
Prostatitis is an infection, so it's treated with antibiotics.
All right.
And those are other prostate problems. And the PSA blood test is not a cancer diagnostic test; it's an indicator of prostate health. So your PSA will be raised if you've got a large prostate. It'll be raised if you've got an infection. It'll be raised if you had sex within 48 hours of the test, or you did a vigorous exercise within 48 hours of the test. But I think those, it's still the only starting point. And then we go on to, having got that test, you've got to ask for the test. You've got to ask your GP for the test. And some GPs are still refusing to test, which is ridiculous. Because
what could be the motivation behind that?
Well, it's because they're mired in the past. Prostate cancer screening does more harm than good from this study 25 years ago in America.
Right.
They don't know that the diagnostic pathway has been improved, and they've not caught up to date. So education is really important, but then education is also important in the field where men are diagnosed with metastatic prostate cancer, are being undertreated. Well, we need to educate healthcare professionals, clinicians better to make sure that they know that what the standard of care looks like. And I've spoken at international conferences now for the last 3 years, and invariably lots of the healthcare professionals there, urologists for example, were not aware of what standard of care was for metastatic prostate cancer. And so we need to do better there, because we are still going to have men diagnosed with metastatic prostate cancer, because not all men, if they get invited for screening, will go for screening.
No.
So, I think if we get sort of 60 or 70% take up for a screening program, that would be amazing. But
I don't know what take-ups are for other screening.
they're pretty awful, to be honest. Yeah,
Right.
not great.
Well, that's our fault. That's nothing to do with the well, maybe partly our fault for sure.
Yeah.
Never mind the medics. We need to step up to the plate, and if we're offered these things, say thank you very much. I'll have some of that.
Yeah, and I think, the Transform trial, they're going to actually, GPs are going to send letters out to men who are in the age group for the trial to invite them for testing. And what I would say is if anybody is listening to this and gets an invite from their GP inviting them to go in for a test under the Transform trial, for God's sake, take it up, because we need as many men to take up the offer as possible. It might catch lots of people anyway early, but actually it will give us a much better outcome from the trial.
Okay, that sounds like a very good place to leave it, Tony. And one final question: if people are listening to this and they're worried in any way, shape, or form and want to find out more about prostate cancer symptoms, what they should do if they're worried about themselves or someone else in their family or a loved one or what have you, where can they go for good, solid, sensible advice and information?
Yeah, lots of great resource out there. Prostate Cancer Research have a tool called the Info Pool on their website, which has got a huge amount of great information on it. But in addition to that, Prostate Cancer UK, they have a plethora of information on their website, downloadable booklets. That's also great. And for any man who is actually diagnosed with prostate cancer, I'm Vice Chair and Trustee of Tackle Prostate Cancer, and we are the only national charity looking after support groups. So we have 150 support groups across the UK. So for men who are diagnosed, we have a mentoring service. We also have the support groups and also support groups for partners as well.
Right. Okay. All that sounds extremely useful and sensible. So, Tony, thank you very much indeed for taking the time to chat today.
It's a pleasure. Thank you for asking me.
Thank you very much to my guests on this week's show. They were Dr. Venetia Leondarchi and Miranda Pasucci, and then Tony Collier, BEM. A big thank you to you for listening, and have a healthy week until next week.
Thanks for listening to the Relax Back UK show. Join me, Mike Dilk, again next week for more fascinating interviews and chat. If you're listening to the podcast version, please subscribe, like, and share it with your family and friends. And have a healthy week. Until next week.